stopped on the point that what makes you suspect that your patient may be suffering from the tumor, which makes them to develop mental disorders. It is the certain evolution of symptoms. What I mean by this, for example, your patient first refers to you with the symptomatics of depressive disorder, for example. They get the treatment, and after a week or a month, for example, they come once again, but they are presented with additional symptoms, for example, dysphagia. And these additional symptoms represent the widening of the tumor, the spreading of it, and corresponds to the structure of the nervous system. Of course, if you have even the slightest suspicion that the patient has a tumor, you shouldn't wait and hesitate. But a lot of times these patients cannot find their specialist, so they already have a certain analysis of the problem. So this helps you to differentiate and to suspect whether the person needs your help or maybe the help of a surgeon or oncologist. And by this we conclude finally. We finally conclude our topic on the organically induced mental disorders, and finally we come to the epilepsy. So I hope this will be brief because I do not have many more time left before. This is also the winter before the group therapy starts. Okay, so epilepsy. All in all, epilepsy is a chronic endogenous organic disease of the brain which can be characterized by partial or generalized spasmodic seizures, and also from a certain point when actually psychiatrists take on the epilepsy, it is also characterized by typical changes in personality and thinking of the patient, which can achieve the degree of dementia. And also, there is also always a possibility to develop acute and chronic psychosis at a certain stage of this disorder, because I have mentioned before, if the nervous system is already compromised by a certain factor, it has already lessened the resistance, it is more willing to develop different mental disorders. And in case of epilepsy, most of the patients, and there are diagrams, for example, for adult patients and for the children patients, is that usually epilepsy starts as a neurological disease, and for a long time, and most of the children start with a neurologist, a long time these patients are managed by a neurologist. But from a certain point, when it is evident that there are also changes from the psychiatric point of view, psychiatrist also joins the team in order to manage this disorder. And therefore, majority of adult patients actually are watched by the psychiatrist. When I was working in the epileptology department and the epileptology ward, we always had on the roundabout not only the psychiatrist but also the neurologist who was conducting their own research. Okay, so clinical picture of the epileptic seizure, of the classical epileptic seizure, is usually represented by paroxysmal activity. Paroxysmal means that this activity is repeated stereotypically from time to time, and it is always very sudden, like a discharge of the neuron's activity, stemming from the impulses in the neurons. There are also pathological phenomena, so it can be motor when we're talking about convulsions. It can be sensorial, so the person may get even strange hallucinations or strange aura-like sensations, like burning on their skin, or maybe strange sounds, or sometimes they may smell something strange, and also autonomic. There may be change in respiration, change in the breathing, change in the vestibular organ, change in the cardiovascular system, and also psychic phenomena. So with usual change of consciousness, for example, up to the point of twilight, change of twilight disturbance of consciousness and such stuff. And we will be talking about all this in details today. There is also such term as epileptic reaction. It is a non-specific reaction of the organism which takes a form of a seizure attack as a reaction of the influence on harmful exogenic factor, for example, febrile temperature for children, and it is actually very, very scary for a lot of parents to witness this, because they immediately think that their child is dying, or for example that their child develops epilepsy. But epileptic reaction is not yet epilepsy, it is just a reaction. It is short-lived and usually will not repeat itself without any ground for it, without any provoking factor. If it repeats, then we are talking about that maybe this child actually had epilepsy which was dormant before this factor, and then they need to get observed and examined more thoroughly. Okay, what else? And there are also epileptic syndromes. So these syndromes are epileptic seizures which develop in case of focal injuries of the brain. For example, tumors, hereditary degenerative disorders, inflammatory, vascular, parasitical. So if there is at least any locus of irritants in the brain, local neurons will respond to these irritants by excitation. And this excitation are impulses which can then spread outside of the locus. If they spread on both hemispheres, they cause the loss of consciousness and the generalized seizure. If they spread partially, they cause only the disruptions of the functions which are in this locus of the disrupted neurons functionality. So in partial seizures, the clinical picture largely depends on the locus of the seizure. Okay, we have talked about this. So yeah, if we have a certain seizure, which is either spasmodic or non-spasmodic, like psychiatric seizure, it is usually a manifestive sign of the disease. And for example, for some people, their epilepsy has affective clinics. So for example, they may get attacks of depressive mood or manic mood, but it is also paired with the change of electric impulses in the brain. And this is important to remember. This is what differentiates such disorders from endogenous disorders of the mood, like bipolar disorder, for example. We will be talking about this in a moment. Okay, I have talked about this. Okay, so once again, etiology is multiple. There are different approaches here. Once again, I have talked about this before, and I repeat again, you need to have a certain talent to have a certain illness. It is not like that the person develops an illness on the base ground. And so these people usually have a certain weakness in their brain, certain susceptibility to certain factor which can cause them to have seizures. Of course, it is also hereditary, so it doesn't mean that all the people with this gene would develop epilepsy, but it means that they have a certain inclination to this disease. And if we refer to psychoanalytical messages, usually in psychoanalytical research, it is regarded that epilepsy is a manifestation of extreme dumping of the emotions. So the person doesn't release emotion right in time, and so these emotions get released on the morbid basis of epilepsy in the form of a seizure, because it was piling up for a certain time and then it is released. Epilepsy, all in all, is a defense mechanism most of the time. Because if you have a predator, for example, and its victim who exhibits a generalized seizure with these convulsions, no predator wants to go around this animal who is convulsing, because this animal is obviously sick. It is not safe to eat it, and it may hurt you in this state. So obviously it is a defensive mechanism. The problem is that in our society this mechanism is no longer interesting, no longer useful for the patient, and therefore unfortunately it becomes a problem, because the seizures are not controlled and the person doesn't choose the time when they happen. So for example, the person may cross the street and they may fall and lose their consciousness. They may be operating some machines, for example, and they may fall into a generalized seizure. That's why epilepsy is included in the list of diseases from which the person is prohibited from working in certain occupations, not to harm themselves and not to harm other people which depend on them when they are doing these occupations. Okay, talked about this, we have talked about that. Okay, so upon the depending on the etiology, the epilepsy can be classified as as primary or idiopathic, genuine, or secondary or symptomatic type to a certain other factor, for example. So when we are talking about idiopathic, I would say that usually the factor provoking the seizure still exists, but its link is not evident right away. When I was working in that ward, there was a patient, girl with idiopathic epilepsy. She told me that she doesn't even know where this seizure comes to her, but what I have noticed, when she was talking to me, she was constantly gazing back and forth at another woman in the ward. And at first, I didn't understand who that woman was. It occurred to me that this woman was actually her mother, who was very overprotective, and this patient was making sure that she would only say the words which would please the mother. This mother was staying overnight in the ward with her daughter in order to make sure that she is safe. And her daughter was already given some medicaments, but on the very next day, she got another seizure. And what do you know? What do you think? Her mother was right besides her when the seizure happened. So I would say that actually in this case, the provoking factor might be the mother. There is probably some psychological conflict between her and her daughter. But it is very hard to treat such thing, because in this case, I would say that medicaments are not enough. The family psychotherapy should be implemented alongside the medicaments in order to ensure the best result for the patient, because her mother was just too firm on her grip with her daughter. Okay, so here is that. We talked about this, we talked about that. What else we need to talk about? Talked about this. Yeah, also what you need to know is that in epilepsy there is a disturbance in the metabolism. Especially in proteins, carbohydrates, fats, water electrolytes. That is why alongside the anticonvulsant therapy, we also implement some electrolytic therapy. And also we are scared of the brain of our patient to become full of edema, because that's usually what causes their death. That is why people with epilepsy actually need to follow a certain diet. So in this regard, they are like people with endocrinopathies, for example, like diabetes mellitus. So they need to follow certain rules in order to ensure that they do not fall into another seizure, apart from taking medication regularly. Okay. So if you talk about mediators, usually the problem with convulsions is linked to the low discharge of the inhibitory neuromediators such as GABA, and to the extreme discharge of the excitatory neuromediators like glutamate. Okay. So yeah. Once again, all epileptic paroxysms can be divided into generalized, partial seizures, and also psychic equivalents, which are usually partial. Okay, it will be gradually become more and more dark here. I hope you can bear with me, because I don't really have any source of light. So maybe this will do. I don't know. Oh, a little bit. Well, not much changed actually. Yeah, nothing changes, unfortunately. Okay, I was shocked. So I have talked about epilepsy, about the etiology. Okay, so once again, what are the clinical characteristics of a typical epileptic seizure? It is sudden, so the person doesn't choose the time when it happens. It can happen on any spot, regardless of the danger to the person's life. So obviously there is no conscious benefit to this seizure. Also, it is short term. Usually paroxysm lasts up to 5 minutes, if it or 7 minutes. If it lasts longer, we should administer the medication. Usually it ceases spontaneously by itself. The recurrence usually has a tendency to grow much more frequent over time, but this is the usual evolution of this disorder. Okay, also, the seizures have photographic similarity. So once again, this hints that the person isn't faking it. The person has no control over it because it happens automatically via the usual traits of the nervous system. Okay. So diagnosis of epilepsy is made on the basis of following insights. So these recurrent seizures changes in the personality, because once again, these patients refer to the psychiatrist once they have this change in the personality. And also the tendency towards progredience. So we can see that this disease actually progresses. Okay. There are also signs of the illness on the EEG, electroencephalography. And this is most important. So I have told you before that we differentiate, for example, mood disorder from endogenous one to the exogenous, that we see these changes on the EEG. So it means that something is impacting the nervous system directly. And so there may be spikes, for example, sharp waves, slow waves, a spike in the wave with frequency of 3 seconds, which are characteristic for absences. That is a partial seizure. That is a generalized seizure, but not with full convulsions of the body. Also multiple spikes, etc. In the epileptoid cabinet, where there was this procedure undertaken, EEG, there was a very big diagram with all these pictures you should look for with these signs in the EEG. And of course, if you don't have enough experience working with these graphs, you wouldn't understand what is the difference between pathological one or a real one. Okay, so in the presentation, you'll see a variety of different pictures of epileptic activity taken by EEG. Okay, so all the seizures can be divided into major spasmodic seizure, usual generalized big one, a minor seizure or absence, which is also generalized, and also epileptic status, which is also generalized, but has no breaks between seizures. So it is a constant seizure which repeats over and over and over again. Okay, so a generalized tonic-clonic seizure or grand mal can be preceded by an aura. So changes in the mood, certain headache, worsened general state. So usually people who have had epilepsy for a long period of time, they usually can feel when the seizure is coming some hours before the seizure. But you need to understand that when there is aura, it means that the seizure is already starting. It is only a matter of minutes when it becomes a full-fledged seizure. Okay. And usually this aura is stereotyped. So, for example, the person sees flashes of light. For example, the person hears a certain sound. This usually is stereotyped. When the seizure begins, it begins with a sudden fall and consists of two phases, tonic and clonic. So when we are having a tonic phase of the seizure, it usually lasts from 20 to 30 seconds. And convulsions involve all the skeletal muscles. They prevail in the extensors, like this, so the person starts extensing. And because of the contraction of the muscle of the chest and abdomen, a certain cry called epileptic cry, because the air passes from the narrowed glottis. The eyes are usually wide open and the mouth is half open. And once again, these convulsions are generalized, so also in the internal muscles. So that's another differential sign that the person is not faking it, because it is very hard for you to control such autonomic functions of your body. So this means that it comes from your internal state. Okay, so here is that. Okay, so convulsions begin from the muscles of the trunk and then pass on to the extremities. Usually the shoulders are slightly raised and inwardly displaced like this, and the arms are abducted and outwardly rotated. Well, if you see like this. Also, the muscles of the legs are not involved so intensively, and then starts the clonic phase. So when we are talking about clonic phase, it is a short-term flexion, contractions of the muscles of the trunk and extremities with rapid relaxation. So the person starts jerking on the floor. The duration of this phase is usually from 2 to 3 minutes. Gradually, these contractions become rarer and rarer, and the person ends these spasmodic contractions. Also, there may be biting of the tongue, because once again the jaw is also inhibited in this state, and there may be blood foam coming out of the mouth, because once again the breathing is uncontrolled, and that's why the saliva, there is also hypersalivation, the saliva becomes full of foam. In old instructions, it was a usual practice to put something in the mouth of the patient during this seizure, in order for them not to bite the mouth, their tongue. But it is actually best not to do this, and right now it is prohibited. Why? Because they will bite off your fingers while you try to do this. If you use something strong for this, they will most likely hurt their teeth, and you will have to pay for the teeth operation for this person, for their prosthetics. Yeah, probably the tongue wouldn't be a problem there, but all the teeth should be replaced. So no, we do not put anything in the mouth of such patients. We just wait for everything to end. Also, a very important symptom of this seizure is that there is mydriasis with aroplexia to the pupils of the light. So the pupils are very dilated. So once again, this is something which is very hard to simulate for the person with histrionic traits, for example, who is also convulsing on the floor. We'll be talking about histrionics as well. Okay. And also hypersecretion is another reason why the person, for example, may even suffocate, and usually they should be placed on the side, because there is hypersalivation, and there is also hypersecretion in the bronchi as well. So after the seizure, the person doesn't wake up immediately. They usually are very asthenic, and they fall into a deep sleep up to the coma. So you may see the relaxation of their muscles at this moment, including the involuntary relaxation, and so they may defecate themselves, they may urinate on themselves involuntarily, because they just relaxed at that point. The reflexes, corneal, pupillary are absent, deep ones may be activated, so you see that the person is in a coma. Also, there may be pathological signs like Babinski sign. After 15 minutes or little or less, the person finally comes to their senses, and after the recovery, they complain of a headache, pains in muscles, and a bad general state. So it doesn't leave you without a trace. It is a very hard state. It is a stressful state for the organism. Another difference from the people with histrionic disorder. Okay. When we're talking about minor seizures or petite mouth absences, they're basically sudden and short term, up from 2 to 30 seconds, disengagement of the consciousness. So, for example, they're very common in kids. And for example, you may see a kid running around, then the kid suddenly stops. Their gaze once again doesn't react onto anything. They are looking straight in front of them. They do not talk. They do not move. And when they come to their senses back from the seizure, they continue running in that direction they ran before, and they continue their activities. For example, if this person is talking, they resume their speech from the point where they have stopped talking, and they will not notice that they were disengaged at that point, because the consciousness is off during the seizure. You will also observe, of course, autonomic visceral reactions. So there may be a change of the color of the face because of the blood vessels contracting. Also, there may be moderate mydriasis as well. Okay. We talked about this. Also, when we are talking about partial seizures, which are not generalized, when the person still has their consciousness on, their symptoms depend on the localization of the seizure. So, for example, there is a Jacksonian one, and it is a form of the typical motor jock on the one of the extremities, which actually can be stopped from generalizing by the view of the patient, if the patient notices it right away. So in the epileptic ward, for example, neurologist was using the neurological hammer, checking the reflexes like this, trying to induce the jock in the patient who is highly ready to get a seizure, for example. And in some patients, I saw these jockings very, very, very vividly. Okay, so here's that. There are also versus seizures. So this is about Chromatograph. zone of the frontal cortex, and versive seizures are called versive because the person turns around. So, for example, because of seizure may look like this, the person is turning around. It is very hard for them to control these seizures. They turn into the opposite side of the hemisphere which is affected. So here is that. Okay. What else? Sensory seizures. So sensory seizures are observed if sensory cortex is involved in this thing. And so somatosensory seizures may have a form of paresthesia or like visual, auditory, olfactory hallucinations, as well as dizziness. Gustatory hallucinations may appear. So those are seizures. There are also autonomic visceral manifestations. So, for example, panic attacks may be a form of this seizure. Also, there are unpleasant, indefinite sensation in the epigastric region, so different synestopathies may be this seizure, accompanied by the feeling of nausea and vomiting. So there is a variety of phases the epilepsy may take, depending on its localization. Okay, we have talked about this. Also, disturbances of psychic function. There may be a partial or absolute paroxysmal motor or sensory aphasia, for example, so the person isn't able to talk or to understand speech directed towards them. There may be difficulties in articulation of words. So in this case, we may also differentiate the epileptic seizure from the stroke, for example, for these patients. There is also sometimes absolute amnesia within a certain, sometimes prolonged, even hours of time period. When the consciousness was clear, behavior was adequate, but the person just doesn't remember what was happening with them. Later, these memories come back. And this is a difference from, for example, dementia and other types of amnesia, where the person loses their memory for all the eternity after that. There may be change in the pace of the thinking, so thoughts may be running and scattering at an unbelievable speed. So once again, here you see that there is a lot of overlapping with other diseases symptoms, but it should be paired, the diagnosis of epilepsy should be paired with the personality changes and also with the EEG, which helps us to understand that right now the person is having a seizure, not like, is not in a manic phase, for example, is not a person with schizophrenia and stuff. Okay, what else? Also, non-proxismal changing of mentality are the typical personality changing which are taking place in epilepsy, and mainly we are talking about the changing of the character traits and the changing of thinking and intellect. There may be also changing of the consciousness, so contraction-free paroxysms, such as twilight disturbance of consciousness, which I have described in the first lesson, yes, and also delirious state with vivid visually, not in the first lesson, but in the second one. There may be also delirious state, on-the-road state, and ambulatory mechanism, automatism. When we're talking about ambulatory automatism, it is a short-term automatic actions with estrangement from the surroundings. And there is also amnesia, of course, after that. There may be also fuga. So fuga is a sudden need to move around and move away from where you are right now. So a person suffering from fuga will take a bus and go to another city, for example. And during this period, they may operate automatically. They will not talk and they will not remember afterwards what was happening to them. So in the city, when the person comes back to their senses, they are like, how did I get here? I want to go home. So such reaction. There may be also trance dysphoria, which I have explained once again in the second lesson. And there may be states of depersonalization, derealization, metamorphopsia, melancholia, also anxiety, such stuff. But once again, these symptoms should be paired with the changes of personality and changes on the EEG for us to understand that this is because of epilepsy, because depersonalization, derealization can be caused by a variety of reasons. For example, I can cause them artificially for myself without any drugs, just because I know how suggestive I am and I know how to do this via psychotherapeutic means. So we should always remember about instrumental examinations, if there are any, for a certain illness we are trying to check out or check in when we are giving the diagnosis for our patient. Okay, so what about this? Yes, psychic disorders connected with the epilepsy. When we're talking about psychosis, yes, psychosis, neurosis, they are may be connected with seizure, so they may appear before the seizure, during the seizure, after the seizure, for example. And we are talking about epilepsy-induced psychosis if the onset is during 12 to 72 hours after the seizure, for example. There may be psychic disorders between the seizures, so acute, chronic, alternative psychosis, and psychosis also caused by drugs, because once again, when your system is already compromised, if you use a certain medication on them, they may react abruptly to this medication, including drugs. So usually they get bad trips in the lightest of cases. Also, there are changes of their personality, disorders, sexual behavior, criminal behavior, for example, and sexual behavior disorders are an interesting group, because most of the times it is not about sex, it is not about attraction, it is about something the person wants to accept in life, something the person wants to experience, a discharge of emotions. And it is interesting which object is chosen for this. So here's that. There may be cognitive disorders, so namely independent dementia, emotion disorders, I have mentioned those already, and different psychotic states. Okay, so when we are talking about personality changes, patients with epilepsy become very pedantic, very meticulous, and in this meticulousness, they may be even very strict to other people, because they want other people to follow the same rules as them. They become very religious and very fixated on idea of being a good person. They usually may also change their speech, so they will use more minuscule parts of the speech to make it like sweeter, kinder, etc. They will be very polite, exaggeratedly polite. And in psychoanalysis, it is mostly connected with them trying to go away as much as possible from this anger, which exhibits itself in paroxysms. Though this, I would say, this flee from these emotions is what causes these emotions to pile up. So it is a bad circle, unfortunately, of symptoms here. What else? Their thinking becomes very rigid and very slow, and it will be even painfully slow in talking with them. So you have to wait until they give you the idea, because they may be very vindictive and very sensitive to any kind of critics. So they will be speaking very slowly, they may think very slowly. They also develop circumstantial thinking, and I have talked about this before, how it manifests during the second lesson, so you may look it up if you forgot. So yeah, about vindictiveness, they will remember if you have a very long time, so it is best not to do wrong to them. So here is that. And of course, they have frequent dysphoric reactions as well. Okay, what else? And this vindictiveness is just because their psychic processes are slowed, so they are just very torpid in these reactions. Okay, so now about dementia. There are no differences mainly from other dementias, so it is a diminishment in cognitive sphere, but there is a clear etiology, epilepsy, for many years before the incidence of this dementia. Okay, so we have talked about this. So psychosis may be acute, which include cloudiness of consciousness, and they may be they are usually transitory, so their onset is acute and recover, and they last from few hours to 2 weeks, so they are very transient. Okay, so here is that. Also on neroid, the same clinical picture as typical neroid, just linked to epilepsy. I have talked about this, I've talked about that. Yes, hallucinatory paranoid psychosis will develop with vivid imagery delusions. So now we are talking about secondary delusions, not primary, secondary, and they're usually unsystematic. And the hallucinations are usually verbal and visual. Okay, so protected in epileptic psychosis, we are talking about protected ones when they continue before 1 month, and they are subdivided into affective delusional ones, delusional, catatonic paranoid ones. When we are talking about chronic epileptic psychosis, they originate at remote stages of the illness, and they usually last more than 1 month. So that's the difference from protected ones. Usually, when psychosis develops, there is a certain decrease in the rate of seizures, and there is normalization of EEG. And this happens because the seizure happens basically in the form of which is unsatisfied previously. So previously it was piling up and given discharge during the paroxysms, and right now it is constantly discharged. So there is no problem with the neuronal activity of the brain at that moment. Okay, usually their delusions are interpretative, and they are of ordinary content, which both is connected with actions of concrete people in certain situations. So it is very basic, like paranoid in old people, for example. Okay, so more common, there are ideas of preference, persecution, poisoning, and jealousy. So projective delusions. Okay. Also, sometimes there is formation of paraphrenic psychosis with megalomaniac delusions having a fantastic content. So now from the projections we jump into the inflation, which is the opposite of these. Much less common are catatonia-like states, so not very common. When we are talking about epilepsy, it is very hard usually to diagnose in children because they develop this state under a variety of reasons, and a lot of times it is just a reaction onto something. Okay, so here is this. Okay, we talked about this. So usually the disease of epilepsy begins with non-spasmodic seizures called absences. Okay. And the different sudden fears, somnambulism as well. Somnambulism also falls into paroxysmal disorders. Disturbances in the mood and behavior, attacks of pain in various organs. Syndromes typical for childhood of epilepsy are called West and Lennox-Gastaut syndrome. So when we are talking about West syndrome, there is a triad of symptoms: spasms in the forms of knots, packs, salam convulsions, disturbance in psychomotor development, and typical changes in EEG. So what about what are Salam's convulsions? In Salam's convulsions, it looks as if the child is like this, so they're stretching like this, and this is involuntarily, once again, for them. Knots, you know what knots are, and packs, once again, the same movement. Usually the illness develops at the age of up to 1 year, more common in boys, and the prognosis is usually unfavorable. Also, it occurs in two variants. It may be a symptomatic one, inorganic lesion of the brain, and also may be an idiopathic one when we're talking about genuine epilepsy. Lennox-Gastaut syndrome manifests in the children from the age of 1 to 8 years, so much older age group, and most frequently in the preschool age. So usually it develops against a background of encephalopathy in the primary form as well. And most common are atonic fits and absences, though there may be also myoclonic, degeneralized tonico-clonic, and partial seizures. The rate of fits, if the rate of fits is high, the epileptic status develops. So continuous seizures without any breaks between them, without coming to senses between them. The treatment is usually not very favorable for these kids. So now about the status epilepticus. It is a complication of epilepsy. This is what we always fear, and usually when epilepsy is not treated, this is what comes after the protracted course of this illness. It requires urgent medical aid because it is a direct danger to the health and life. So it can be caused by the inadequate treatment as well. So sharp reduction of the dosages or discontinued taking of the anti-epileptic drug preparations, resistance to them, addiction to other hazards. It causes disturbances, the epileptic seizure, epileptic status, causes disturbances in the respiration, cardiovascular activity, and metabolism. Okay, so what do we do about status epilepticus? First, when we see the patient who is convulsing on the floor, we need to make sure that they do not hit their head too much, that there is no objects or dangers, imminent dangers around them. They should be placed on their side in order not to suffocate, and for the tongue not to fall down into the throat. We wait for 5 minutes, 7 minutes. If seizures stop, okay, fine, this was a typical seizure. If the seizure doesn't stop, we should administer diazepam intravenously slowly for 10-20 milligrams of 0.5% solution in glucose. If there is no effect, we can repeat the administration after 2 hours. If there is no effect, now we switch into the anesthesiology department. Now we infuse intravenous solution of hexanal or sodium thiopental at a rate of 1 millimeter per 10 kilograms of the patient's body. Simultaneously, we also administer sodium thiopental to the hexanal intramuscularly, so both intravenously and intramuscularly. If it doesn't simultaneously with this, we also use lytic mixture of timiperidine hydrochloride, analginol, and diphenylhyramine hydrochloride and novocaine intramuscularly. I'm not talking about dosages here because you have dosages in your presentation and you wouldn't remember the dosages anyway when I'm talking about them. Because we are scared of edema of the brain, we need to administer furosemide or mannitol, so diuretic drugs. Also, we may use prednisolone in order to help with the cardiovascular disorders. As well as spinal puncture is made in order to release the tension in the brain. Also, to improve cardiac activity, we use corglicon or digoxin intravenously. If the blood pressure is increased, we use papaverine, magnesium sulfate in order to lessen the blood pressure. Pentamine intravenously. Okay, I have talked about the help. Now, about the treatment of epilepsy. Okay, so 1 minute. I will return shortly. Yes. Okay, let us continue. There is very little of the topic left. So, how do we treat epilepsy? There is a variety of different anticonvulsants, and the treatment should be very complex and prolonged. I have already mentioned that there should be also a certain diet the patients should follow in order to prevent the appearance of the convulsions. especially when we are talking about sodium intake, because once again it helps our muscles to work, so we don't want to take too much sodium for such people. Okay. What we have talked about this. Yeah, also, if the patient with epilepsy knows what triggers the epilepsy, they may have photosensitivity, for example. They need to avoid this stimuli when they know that they will trigger their seizures. When we are treating comorbid mental disorders in epilepsy, this depends on the nature and symptomatics of these disorders, so we may use neuroleptic tranquilizers, antidepressants. But today we will be talking about the anticonvulsant therapy. Okay, so main anti-epileptic drugs, the most famous ones are Benzodiazepines, like phenobarbital as well, also valproates, and like lamotrigine, carbamazepine. So most of these drugs operate on the GABA AGIC system. So the difference is mostly which type of epilepsy they are effective against. So I will be focusing on the mechanism and on the recommendation, what we use this for. So for example, phenobarbital is used mostly for focal and generalized tonico-clonic and myoclonic seizures. And it can be contraindicated if there is a sensitivity to it, for example. Benzodiazepines, which unfortunately can cause addiction if administered more than 2 weeks. They are very good for focal seizures, absences as well, tonic and generalized tonico-clonic seizures in the cases of resistance to other drugs. So they are the second line of the treatment here. Also, the thing is that they are used as well for epileptic status. What else I need to say? Also, there is etosuximide, and it is used for abscences. It mostly blocks the discharges of the neuron membranes. Also, there is a benzonal, which is a prodrug of phenobarbital, the same prescription, but it is also effective against psychic seizures, while phenobarbital only about muscle seizures. Okay, so about this. Also, valproates, and they are basic ones. So we start with valproates when we try to treat epilepsy, and they are very effective against generalized epileptic seizures, as well as focal ones. So a very broad recommendation for this treatment. Okay, so there is also carbamazepine. This drug is used in focal epileptic seizures only. It is contraindicated as well when there is a hypersensitivity, so allergy or bradycardia. When we're talking about lamotrigine, this drug can be effective in absences in Lennox-Gastaut syndrome. Okay, it is once again contraindicated if there is an allergy to it, and it also operates on the sodium channels. Also, there is topiramate, which blocks strain-dependent sodium channels once again, and also potentiates the GABA activity. It can be administered for simple and complex partial seizures with or without generalization, major tonico-clonic seizures, and different falls in Lennox-Gastaut syndrome. It is also administered in the case of resistance to other drugs. So all the others, we use valproates as the first line. Benzodiazepines and topiramate can be used in case anything else fails, and like carbamazepines, lamotrigine can be used in the second line. What you need to know about these drugs is that anticonvulsants in lesser dosages than for epilepsy are used in order to stabilize bipolar disorder, because it also has a paroxysmal feature, mainly bipolar disorder with the features of mania, maniacal phases, and these drugs unfortunately can cause a lot of problems with the neural tube of the child if we are talking talking about pregnant patients. So for pregnant patients, you should be very, very wary about this effect, and you should inform your patients that this may have a teratogenic effect. Some of the effect of these drugs can be diminished via ingestion of folic acid, but a lot of times it is not enough. So be very careful. That's all for today. Thank you very much for your attention. See you on the next lessons.